Good afternoon, everyone. Welcome to today's ME/CFS Stakeholder Engagement and Communication Call, which we call SEC or SEEK. My name is Christine Pearson, and I'm the Associate Director for Communications in the division where ME/CFS program is located within CDC. As you may know, we host these SEC calls twice a year as part of our regular outreach and communications activities to provide information for people with ME/CFS, as well as their loved ones, clinicians, and anyone else interested in the disease. Our goals during these calls are to provide updates on the work of CDC's ME/CFS program and for you to hear from external experts in the field. Today, we'll hear program updates from Dr. Jennifer Cope, a medical officer with CDC's Chronic Viral Diseases branches. Then we'll turn it over to our guest speaker from Kaiser Permanente's Division of Research at the Oakland Medical Center in California, Dr. Jacek Skarbinski. After Dr. Skarbinski's presentation, we'll have a Q&A session. During today's Q&A, you'll have the opportunity to ask questions through the webinar platform or by phone if that's how you joined today. We'll provide more information on that when we get to the Q&A section. Before we start, I'd like to remind everyone this call is open to the public, so please consider that before sharing personal information. We're also recording this call. Please disconnect now if you have any concerns about recording. We will post a transcript and video as soon as possible after the call is complete. If you'd like access to closed captioning or to read along with the text of the program update, the links for both should be posted in the chat box. Now, we'll turn it over to Dr. Cope to start the program.
All right, thank you, Christine, for that introduction, and welcome everybody to the 21st SEC call. I would like to begin with recognizing the continued dedication of the many ME/CFS organizations and advocates that work to bring awareness to this serious long-term illness. As many of you know, we observed ME/CFS International Awareness Day last Friday on May 12th. A highlight of CDC's participation in ME/CFS Awareness Day this year was the lighting of the Visitor Center and Welcome sign at CDC's main Atlanta campus in blue lights on Friday evening. And just a reminder, with summer rapidly approaching, the sun is setting as late as 8:30 here in Atlanta, and that's when the lights became most visible. And we arranged to have photos taken at that time, which you can see here on the screen. CDC also marked ME/CFS Awareness Day with new social media posts each day in the week leading up to May 12th, and a new CDC ME/CFS Awareness Day features webpage, which can be found at our ME/CFS website, which is www.cdc.gov/ME-CFS, and we'll put that link in the chat. This page has also been translated into Spanish. On this new webpage, visitors will find recent program updates, including a summary of education and outreach activities, and information about ME/CFS and post-COVID conditions, also known as long COVID. One important item we continue to highlight is the October 1st, 2022 release of the new ICD-10 codes, which now includes a code specific to ME/CFS. To help observe ME/CFS Awareness Day and continue to raise awareness of ME/CFS in children and adults, the ME/CFS program developed a new podcast that reviews pediatric ME/CFS and how it compares to ME/CFS in adults. Our medical officer, Dr. Nanda Issa, discussed ME/CFS in children and younger people and shared the current resources for healthcare professionals and families. Dr. Issa also participated in a podcast with staff from the Journal of School Nursing in February 2023 to share results from the first phase of our ongoing school-based active surveillance project. You can find links to both podcasts on our ME/CFS features page. Finally, in February 2023, we featured a clinician outreach and communication activity, or COCA call, titled Evaluating and Supporting Children and Adolescents Presenting with Post-COVID Conditions. A link to this webinar can also be found on our website. We also highlighted the collaboration with WebMD's Chief Medical Officer, John White, who interviewed a person with ME/CFS, and Dr. Valerie Montgomery Rice, President of Morehouse School of Medicine, as part of a series to describe findings of the general public's knowledge, attitudes, and beliefs about ME/CFS. These videos will be available to watch on WebMD's website until May 26th, and we encourage you all to take a look. CDC's ME/CFS program continues to strive to raise awareness of the disease through educational efforts and collaborations. I'll now provide updates on some of these activities. We continue to partner with the National Association of School Nurses to not only collect information about ME/CFS in school children, but also to educate school nurses about the disease. An overview of the school-based active surveillance project can be found on our website under the section called CDC's ME/CFS program. The first phase of the project was started in 2018 and completed in September 2021. And we shared some preliminary stages of this work at the 2022 IACFS ME conference, which was held online. The manuscript from the first phase was recently published in the April 2023 issue of the Journal of School Nursing. We are currently in phase 2 of the project, which started in 2021 and will continue until 2024. In this second phase, we continue to expand the work to additional states. The approval process for information collection was just completed this month, and the school nurses are now entering the data collected from the 2022-2023 school year. Since the beginning of this project in 2018, 7 courses have been developed to build school nurse capacity on the school-based active surveillance and ME/CFS. There have been over 33,000 people who have registered and downloaded these courses. Meanwhile, we've continued to publish findings from the multi-site clinical assessment of ME/CFS, or MCAM study, for which data collection was completed in 2020. As of April 2023, there have been 8 peer-reviewed publications from the MCAM study. These include publications describing the study protocol, assessing orthostatic intolerance abnormalities, exercise testing, validating instruments to measure fatigue, sleep, and pain, evaluating methods of extracting medication data, and natural killer cell function testing methods. Previous SEC calls, we mentioned that we were working on describing co-occurring medical conditions in people with ME/CFS. As a result, we submitted 2 abstracts to share these preliminary findings at the 2023 IACFS ME conference, which will be held July 27th through the 29th in Stony Brook, New York. One abstract assesses autonomic dysfunction in people with ME/CFS, and the other abstract describes chronic overlapping pain conditions like fibromyalgia and irritable bowel syndrome in people with ME/CFS. We plan to use these analyses to help tailor our education materials for clinicians who manage care for people with ME/CFS and overlapping conditions. We are also in close communication with the NIH about linking MCAM biospecimens to the NIH's search tool, which is available to researchers. When the linkage has been completed, we plan to make the baseline clinical epidemiologic data collected for MCAM available through the MAP ME/CFS data portal. With the sharing of biospecimens and data from our MCAM study, we hope to generate more research interest and publications to advance ME/CFS research. Now I'll provide updates on some of CDC's direct-to-healthcare professional educational activities. As of April 2023, we have partnered with Medscape to produce 6 online courses and 1 print supplement. Through the online courses, we've reached almost 114,000 learners, 47,000 test takers, and issued about 38,000 course completion certificates. 5 of these courses have reached the time limit for renewal of continuing medical education, or CME credits. However, the courses can still be viewed on the Medscape website. CDC is also sponsoring a new Medscape Spotlight CME course called ME/CFS Diagnosis and Management in the Age of COVID, Expert Insights. The expert faculty participating include Drs. Anthony Pomeroff and David Sistrom from Harvard Medical School, and Dr. Lucinda Bateman from the Bateman Horn Center, an ME/CFS specialty clinic in Salt Lake City, Utah. We anticipate Medscape will launch this course at the end of the year. Next, we'll turn our discussion about our work and plans regarding post-COVID conditions or long COVID. As you know, the similarities between ME/CFS and long COVID offer a unique opportunity to study and gain a better understanding of chronic conditions that begin after an infection. We are leveraging interest in study of long COVID to raise awareness of ME/CFS and related conditions among members of the healthcare community. In particular, I'd like to highlight an expert commentary by our program that was recently published on the Medscape website. The article is titled "Treating Long COVID Brain Fog with ME/CFS Guidelines." It specifically focuses on brain fog, which has long been a symptom in people with ME/CFS. In the article, we discuss 5 things to know about management of brain fog in ME/CFS and how this experience can be applied to treat cognitive symptoms in people with long COVID. In addition, early findings from several of our long COVID projects will be presented at the IACFS ME conference this year. One project, COVID Up, which stands for COVID, Understanding the Post-Viral Phase, is a study based in Southern Florida among adults. This project focuses on Hispanic or Latino people who tested positive for the virus that causes COVID-19 and still had symptoms more than 3 months after their COVID infection. A group of patients who fully recovered from COVID-19 is also included as a control. The study uses surveys to assess participants' health over time. A subset of participants will have in-depth physical, cognitive, and medical tests to further characterize their illness. As these same tests have been performed on people with ME/CFS in previous research, the investigators plan to use the information gathered during this project to better describe similarities and differences between long COVID and ME/CFS. Our program will present 2 abstracts from this study at the conference this summer. The first will describe symptoms in people with long COVID and is titled "Impairments in Cognitive, Physical, and Social Functioning Among People with Long COVID." And the second will focus on post-exertional malaise in people with long COVID. Another long COVID project, the Multi-Site Study of Post-COVID Conditions, or MPCC, collected health data from medical charts to describe the health and medical care of patients at clinics designed for post-COVID care. This project will help classify the types of post-COVID health problems and care needed, as well as describe the healthcare patients received in these dedicated post-COVID clinics. An abstract from the study that focuses on ME/CFS-like illness among patients in these 3 post-COVID clinics was accepted for an oral presentation at the IACFS ME conference, and a manuscript is currently under development. In addition to the oral and poster presentations at the IACFS ME conference, CDC's program is also co-sponsoring a workshop with the American Academy of Physical Medicine and Rehabilitation on addressing ME/CFS-like symptoms in long COVID patients. We are also planning another CDC COCA call in June on how primary care providers can assist long COVID patients in returning to work. Speakers will be from CDC's National Institute for Occupational Safety and Health and the American College of Occupational and Environmental Medicine. One of our other projects, COVID Relief, which stands for Research on COVID Long-Term Illness Effects and Risk Factors, in partnership with the University of Washington, tracks electronic health records of patients who test positive and negative for the virus that causes COVID-19, and documents symptoms and medical conditions for about 2 years after that infection. A subgroup of patients who previously tested positive for COVID report on their ongoing health symptoms and provide blood and saliva specimens to help us assess whether there are genetic and other risk factors that may lead to delayed recovery from COVID. Multiple analyses using these data are ongoing. A manuscript on incidence and predictors of fatiguing illness following COVID-19 should be submitted for publication soon. We're excited to have reached the stage of being able to disseminate the findings of the long COVID projects that were initiated during the earlier phases of the pandemic. Before we turn it over to our guest speaker, I'd like to remind you that if you have suggestions for speakers or ideas for other topics for future SEC calls, please email us at mecfssec@cdc.gov. You can also use this address if you'd like to be added to our email notifications about upcoming calls. And finally, a reminder that the transcript of this program update, along with a full transcript of the entire SEC call, will be posted on our ME/CFS website. Now I would like to introduce our guest speaker, Dr. Jacek Skarbinski. Dr. Skarbinski is a physician research scientist at the Kaiser Permanente Division of Research and a practicing infectious diseases and HIV medicine specialist at Kaiser Permanente's Oakland Medical Center. He is part of the Permanente Medical Group Physician Researcher Program and serves as co-chair of the Kaiser Permanente Northern California COVID-19 Clinical Research Coordinating Team. Dr. Skarbinski has been working on the ME/CFS consultative service at Kaiser Permanente since 2020 and has been engaged in ME/CFS epidemiologic research since 2019. Dr. Skarbinski earned his MD at Stanford University School of Medicine after completing his BA at Cornell University. He completed his internal medicine residency at the University of California, San Francisco in the San Francisco General Internal Medicine Primary Care Track. He served as an Epidemic Intelligence Service Officer at the CDC and completed an Infectious Diseases Fellowship at Emory University School of Medicine. He is the Kaiser lead investigator on the CDC-sponsored Emerging Infections Program project, Surveillance to Optimize Protocols for Early Identification and Subgrouping of ME/CFS, which we've shortened to STOP ME/CFS, and the COVID Standardized Evaluation of Long-Term Effects, also called COVID Select. His presentation today is entitled Myalgic Encephalomyelitis Chronic Fatigue Syndrome-like Illness Following COVID-19 in a Large Integrated Health System, Findings from the STOP ME/CFS Study. Welcome, Dr. Skarbinski.
Thank you. Thank you. It's a pleasure to be here. I'm gonna get my slides up. Great. I think you can see my slides right now. Thank you so much. It's a pleasure to be here. So my name's Jacek Skarbinski. I work for Kaiser Permanente, Northern California. And just to tell you a little bit about our health system, it is a large integrated health system. We serve over 4.6 million people across Northern and Central California. And we have existing hospitals, over 22 hospitals and 250 medical clinics that serve all of the patients in our catchment areas. And we provide all preventive and curative clinical services to this population. And today I'm going to be speaking about sort of two of my big research areas and things that I'm very passionate about. Myalgic encephalomyelitis, chronic fatigue syndrome, or ME/CFS, and COVID-19 and that intersection. So we can agree that ME/CFS causes substantial morbidity. And however, when we look at our health system and many health systems, we've always recognized that we both underdiagnose it, so patients who have ME/CFS are not recognized by the health system and don't receive care in the clinics, or overdiagnosed. Patients have diagnosis in the chart of ME/CFS who don't necessarily meet the diagnostic criteria. And around 2019, through my colleagues, Dr. Champsey, who's very active in our clinical program, we were approached by the CDC, and we started working with the CDC to think about how to tackle this question. And we started off with designing a study to try to figure out how much ME/CFS is in our health system. And we realized that we needed to do something that includes patient self-report. We realized that it couldn't be based on medical records. We're a large medical system. We do a lot of electronic medical record studies. For this type of study, we really needed to go out to be able to somehow capture patient experiences. The question was, there's 4.6 million people in our system, about 2.7 million adults. How are we going to talk to all of them? We can't. That's a gigantic study. And ME/CFS in standard prevalence studies done by CDC and others is about 0.5% to maybe up to 2% in the population, which means we would have to reach out to a large number of people in order to be able to recruit persons who had ME/CFS. So we set about thinking about how to use the medical record and how to create a risk score and use the data we have in the medical record to try to identify persons who might have ME/CFS. And that's what we spent 2019. That's what we spent on in 2019. And then, unfortunately, something happened. COVID happened. SARS-CoV-2 emerged, right? March of 2020, SARS-CoV-2 emerges. Pretty much very soon after the first cases of SARS-CoV-2, we recognized that people are having long-term symptoms. But by the summer of 2020, and definitely by the end of 2020, we are hearing post-COVID conditions. For those of us who've worked on ME/CFS, you recognize that, hey, viral triggers have been associated or have been a trigger for ME/CFS. COVID could be one of these triggers. And so we went back to the drawing table and redesigned how we were going to tackle this. And we basically created this study that tries to get at both questions. And we basically decided that from our big HER system, from about 2.7 million people, we're going to try to find everybody who has a diagnosis to see if we can confirm their diagnosis, everybody who's got a post-COVID conditions diagnosis. We're going to use our high-risk score that we developed earlier to try to find persons who might be or have some records, some things in our health systems that suggest that they might have chronic fatigue. Things like, for example, multiple fatigue diagnoses are recorded in the medical record, multiple visits for fatigue. And then we took everybody else and looked at them, those who had COVID, and found a group of people who did not have COVID. In 2022, we reached out to almost 100,000 persons at Kaiser Northern California, all adults, and enrolled 9,800 people. They we had electronic medical record information, and we did a very detailed electronic survey with self-reported symptoms. Symptoms that allow us to classify whether or not they meet the criteria of ME/CFS, the IOM criteria. Also looking at other symptoms they might have, functional status, and then scale mental health assessments and others. So basically a wide battery of tests that let us both make a diagnosis or identify people who might have had ME/CFS or MECS, what we call ME/CFS-like illness, because we're not making a diagnosis, and assess their other characteristics. And based on this questionnaire and the data that we have in hand, we basically looking at duration, so more than 6 months, frequency, moderate or severe frequency, severity, moderate or severe severity, just like the IOM criteria. We are able to identify people who have ME/CFS-like illness, and then we group them into 2 groups. One group that basically said, look, we have everybody's COVID history. They said these symptoms all started after COVID, after my COVID episode. And we identified a group of patients who report ME/CFS-like illness symptoms after a COVID-19 episode. We found another group of patients who had ME/CFS-like illness, met all the criteria, but was completely unrelated to COVID. They may or may not have COVID, but the symptoms were predated COVID or were unrelated to COVID. And the last is the large group of patients who did not have any ME/CFS-like illness. And this is what we found. So about 50% of people in our system, so 2.6 million people, just to give you big numbers, 2.6 million people, half of them had COVID. So 50% of our population has had COVID. Basically, I said have at least one COVID episode. The other half did not have COVID. And if you look at this, about 2% meet the criteria for having ME/CFS-like illness. Okay, so severity, frequency, duration of symptoms of all the categories. When you break that down, about 6,000, so it's about 1 in 200 people who've had COVID report symptoms after their COVID episode that are consistent with meeting all the criteria, duration, frequency, and severity for ME/CFS-like illness. And the rest, about 44,000 people, have ME/CFS-like illness in our system, but is unrelated to COVID. And so for the rest of the study, we're going to compare these three groups. We're going to think about how they're similar and how they're different. So almost every single slide is going to be set up in the same way. We're going to be comparing these things. And so column 1 here is chronic fatigue syndrome after COVID-19. Column 2 is without COVID-19, and column 3 is no ME/CFS-like illness. So first thing I want to point out is that obviously in the first two columns, everyone has 100% for fatigue, post-exertional malaise, and unrefreshing sleep because they have to. That's the diagnostic criteria. But you can see that orthostatic intolerance right here is much less common in the group that has ME/CFS-like illness after COVID-19. And then the last thing is I want to look at duration of symptoms in our group that has ME/CFS-like illness after COVID-19. Duration of symptoms is about 2 years, which makes sense because the pandemic we're about 3 years into it right now. Whereas the other group has a very long duration of symptoms, approximately 9 years. So they've had fatigue symptoms and other symptoms for approximately 9 years. Also, I want to point out that in the people who do not meet criteria at all, about 19% report severe frequent fatigue, and then about 26% report unrefreshing sleep. So these are fairly common symptoms in the general population. So next, I want to kind of go through the demographic characteristics. And the first thing I want to point out is that this group that has ME/CFS-like illness after COVID-19 is younger. Average age is around 36 years compared to 45 or 50 for the other two groups. And they are more likely to be Latinx or Hispanic, about 45% of them. There's a female sex predominant for both groups. And then there is some relationship with obesity. We have a higher percentage of people in both groups with ME/CFS-like illness who have a BMI or body mass index greater than 30. And then lastly, a little bit about their sort of COVID history. So this group of people who have ME/CFS-like illness after COVID-19 are slightly less likely to be vaccinated, only about 75% compared to 90% plus. And then most of the infections, when we can track down exactly when their infection occurred, we have pretty good tracking of what variant is circulating at what time period. So we use calendar time to carefully describe which variant you are most likely to be infected with. About 74% had their episode of COVID-19 that precipitated this relationship with developing ME/CFS-like illness during the pre-Delta period. So before Delta, before Omicron. So next we assessed symptom severity and look at differences in symptoms. And again, we're always comparing the three groups. And just to kind of orient on your slide, so this is percentage of people with symptoms is on the y-axis. The symptom categories there are on the x-axis. The symptoms are organized in the sort of order of frequency that they're seen in people who do not have ME/CFS-like illness. So think about it, reference population comparison group. And you can see, for example, in the first column here, first bar, set of bars here, muscle aches and pains are common maybe in 18% of the general population, people without illness, but they're much more common in both people with ME/CFS-like illness after COVID-19 and ME/CFS-like illness without COVID-19. And you can see that both groups of patients are more likely to experience almost all of these symptoms. And this is, by the way, we've actually filtered this out. So these are symptoms that meet certain severity. So they're moderate to severe, severe on the severity scale, and moderate to severe frequency. So this is pretty substantial symptom burden. And you can see that for every group here, that both patients with ME/CFS-like illness after COVID-19, which is in the light green, are more likely to have these symptoms than people who do not have ME/CFS-like illness. And same thing for people with ME/CFS-like illness without COVID-19, also substantially higher. And when you compare the two groups, those who have it after COVID-19 or chronic fatigue syndrome after COVID-19 seem to have a slightly lower symptom prevalence than people with ME/CFS-like illness who did not have COVID-19. Next, we did the sort of same comparison, and the setup is here is exactly the same. The charts are set up in the same way, but here we're looking at physical, emotional, and social functioning. Same set of setup. This is a T-score. This is a score. 50 is about average. So if you survey a general adult population, most people will score around 50 on this. This is normalized. So 50 is the average. And you can see that the categories are again organized with decreasing scores for the group that has no ME/CFS-like illness. And you can see the two bars that both patients with chronic fatigue syndrome, whether after COVID-19 or without COVID-19, have much lower scores, significantly and substantially lower scores for both pain, physical function, energy fatigue, emotional well-being, general health, and social functioning. In most cases, both groups of patients with COVID-19 and without COVID-19 having similar levels of impairment, except for pain, where one group appears those with ME/CFS-like illness after COVID-19 appear to have less pain or higher, less pain than those with ME/CFS-like illness without COVID-19. Next, we look at sort of an anxiety and depression. And again, the chart here is set up in the same way. Those without chronic fatigue syndrome are in the dark blue here on the right. And you can see that around 20% of them meet criteria, diagnostic criteria through either a PHQ-8 or a GAD-2 for depression or anxiety, respectively. Whereas both groups with chronic fatigue syndrome, whether after COVID-19 or without COVID-19, have substantially higher scores, and almost 70 to 80% of them meet criteria for either depression, moderate to severe depression, or moderate to severe anxiety. And lastly, I want to talk a little bit about occupational status, and this is the ability to engage in the workplace. The charts are set up in exactly the same way. Those without chronic fatigue-like illness are in the dark blue on the right, and you can see. I think the most important thing is that when we look at the group that's unable to work due to disability, patients with ME/CFS-like illness that's not associated with COVID-19. Remember, duration of symptoms, average duration of symptoms is 9 years. About 24% of them have had to go on disability because they're no longer able to work, compared to the other groups, which are around 2%. So much lower engagement in the workforce. Notice that those with ME/CFS-like illness after COVID-19, so they've got all the symptoms. We've seen the symptomatology in the first slide. We've seen the impairments in physical, social, emotional function scores on the next set of slides. You notice that that group is younger and actually still more likely to be employed. All right, so I want to kind of take it back, and I want to take us a little bit through a little thought exercise and summarize here. So the main takeaway point from this, what we're looking at, is that the burden of ME/CFS-like illness after COVID-19 might be very large. And I did a little math here for us to show us what this looks like in our kind of study. We've got about 2.5 million people. I showed you 50% of them had COVID-19. And I say that 1 in 200 develop ME/CFS-like illness after COVID-19. I did the math for us here, and we have about 6,700 people, which doesn't seem like that much. But I want us to multiply it out for the United States and think about what the burden of this might be in the United States and the scale of the problem that we might be seeing. We have 258 million adults in the United States. Our statistics here, and approximately, is that probably about half the US has already had COVID-19. If we apply this 1 in 200 will develop ME/CFS-like illness after COVID-19, we're going to get about 670,000 people. I've added a confidence interval in there because our estimates are population-based estimates. I could spend hours talking about how we produce them, but they are designed to produce population-based estimates, so real-world estimates of what the burden might be. We're looking at 670,000, and the estimates may be between 177 to 1.1 million. This is a really large number of people. Remember that the US has experienced about 1.1 million deaths overall from this. So this is a large group of people that might have ME/CFS-like illness after COVID-19. And then the last thing I want to leave us with is, if we think about what are we seeing, we've shown, and with this study is really showing a very high symptom burden. This is 6 months out, so this is already after the initial episode, more than 6 months after the episode. Real impairment in physical, emotional, and social functioning, and real increases in depression and anxiety. I would like to thank the CDC for supporting this work, as well as the NCI and the NIH and my local institution. And I'd love to take questions. I think I'm going to stop sharing. Yes?
Thanks for that presentation, Dr. Skarbinski. We'll now move on to the Q&A portion of our call. There are 3 ways to ask a question. If you're joining on Zoom, you can raise your hand by clicking the raise hand button under the webinar controls at the bottom of the screen, or you can type your question into the chat box, which is being monitored by the CDC team manager on this call. If you're joining by phone only, you can enter *9 on your phone to join the question queue. And when we announce that it's your turn, press *6 to unmute yourself. While everyone gets a chance to submit their questions, I'll go ahead and kick us off with a question that came through during the presentation. So, Dr. Skarbinski, has this project influenced how Kaiser approaches ME/CFS?
Yeah, it's an interesting journey. You know, our how we're thinking about our clinical care actually mirrors how we're thinking about our study, because we started out as a ME/CFS consultative service and trying to provide services and trying to educate all of our providers about how to identify patients, and then how to do standardized assessments and provide care across our very large geographic area. Just to give you a sense, we're a very large system. We got a large geographic area, so it's like 8-hour drive, whichever direction you go, in order to see it. So providing services, I told you, 22 medical centers, 250 medical facilities. That's a huge breadth. So we're working hard. We're working hard to organize that. And then COVID came. And you know, when people first described post-COVID conditions, and 3 years in, we're still sort of halfway there in deciphering this, it's a very complicated problem, because people were describing everything. Some things that matched chronic fatigue syndrome, but many things that were unrelated to chronic fatigue syndrome. And people have described end organ diseases, so thromboembolic disease, myocarditis, pulmonary disease, acute lung injury, things that are pretty much have a home somewhere within the rest of medicine, as some subspecialty that takes care of it. Cardiologists, pulmonologists, hematologists, and then other symptoms that are clearly chronic symptoms, new findings, but are different than chronic fatigue syndrome. They don't meet the criteria. And I think we actually had started 2 programs. So we had a post-COVID conditions program and a chronic fatigue syndrome program. And now, based on this, we're thinking about how they overlap and how they merge. And I wouldn't be surprised, and I don't know, we'll know by the time we finish this study, because we've got a few more pieces to it, where really the bulk of our care is going to be in this population treating chronic fatigue syndrome.
Great, thanks so much. So the next question is, I think, a little bit of a clarification question, and I think it's important to maybe ask this now before the rest of your answers. So the question is, what is meant by ME/CFS-like illness versus saying ME/CFS illness?
That's a great question. And so we use this phrase, ME/CFS-like illness, because we are not interacting with every single, all 9,000 plus, 9,800 plus participants in our study. We are using their survey responses, what they say on a survey. We're using the same criteria, but we are not doing a clinical diagnostic evaluation. And that's actually really important because there may be some people who report all of the symptoms who may not have chronic fatigue syndrome per se, but another condition. And we're not able to tease that out because we don't have a clinical component. And I do feel that chronic fatigue syndrome, ME/CFS, to make a diagnosis needs to have a clinician, preferably trained with experience with ME/CFS, making that diagnosis. That I don't feel comfortable making that on a survey. But they clearly meet all the criteria. And as we've shown you, they have many of the sequelae that we would expect.
Thank you. The next question is, what do you make of the differences you found between people with ME/CFS-like illness after COVID versus people with ME/CFS-like illness without COVID? Might the length of time with ME/CFS account for some of that difference or the differences?
Yeah, that's a great question. I think that's a large part of it. And a lot of what when we started out thinking actually is, can we find people who are early in their disease course? This was pre-COVID. This was one of the big questions we had. I think that is the duration of symptoms is a large component of that. 2 years versus 9 years. I will give you a very specific and clear answer in about 6 to 9 months because we are doing a repeat survey of everybody. We're in the process of doing a reassessment of everybody in terms of symptoms, functional scales, et cetera. And I think it's going to be very important to understand really well how well we're doing in terms of the stability of these symptoms over time. So I think we're gonna have a better answer to this question, but I think duration of symptoms is the big difference.
Okay, great, thank you. So how is ME/CFS diagnosis documented in the Kaiser medical record? And what are your expectations about being able to track diagnosis of the ME/CFS going forward?
That's a great question. So we use standard ICD-9 and ICD-10 diagnosis codes. We actually have an overlay on top of them in terms of we have a much richer diagnosis code list that will map onto a single diagnosis code labels, I guess I would call them, that would match onto the diagnosis code itself, because ICD-9 and ICD-10, which are required to use in American medicine, are rather limited in some ways. So we have our own labels that we use. We're working hard to try to get some real specificity to our diagnosis codes and who we diagnose.
Thank you. So the next question is, it looks like from your graphs that the group ME/CFS with no COVID may be sicker than even the after COVID group. Is this a reasonable observation? And if so, do you have any hypothesis why this may be the case? Does it have to do with the duration of the illness?
Yeah, as I mentioned before, I do think that the duration of illness is the key element why those two groups look different. There's also some differences in age. One is younger than the other, but I think duration of symptoms is probably going to be the big driver.
Okay, great. Thanks so much. Might depression or anxiety, infection-induced ME/CFS be caused by the interferon response to infection?
This is a great question. I don't know the answer. Traditionally, ME/CFS is not considered to have. You're allowed to have comorbid depression or comorbid anxiety. So it's possible to have both, but they are unrelated per se. Now, I don't know in this study why we're certainly seeing a lot of anxiety and depression symptoms, and we're definitely going to explore that further.
All right, great, thank you. So next, from our folks who have their hand raised, I have one that doesn't have a name, but it's a 646 number that ends with 125. Give you a second to mute. Okay, we will
Hi,
come.
Eric Johnson here.
Yeah, okay.
So I'd like to say that I'm an Incline Village survivor,
Hello?
original prototype for chronic fatigue syndrome.
Hello?
Hello.
Oh, sorry. I was asked to unmute.
Yes, please go ahead.
Ma'am, are you still here? I'm sorry, I don't have names. Okay, why don't we, sorry about this, everybody. Let me go
I
to.
got a
Hello?
simultaneous unmute signal.
Yes, hi, I just unmuted. Can anyone hear me?
Yes,
Yes.
Oh.
No, we can't. I'm sorry. Okay. Let me go to a different room real fast, and then we'll see if we can get that figured out. I'm sorry, everybody, for the problem. So this question I think is meant for CDC. So it says studying long COVID alone does not help people with ME. Will you be including ME patients in your studies that have long COVID patients?
Yeah, this is Jennifer Cope. I can speak to that. So one of the in the update, one of the studies I mentioned, the COVID Up study is one that comes to mind. That is a study that's being done specifically doing some of the same tests in the long COVID patients that have been done in the MCAM study. And so the intent there is to be able to compare similarities and differences among long COVID and ME/CFS patients.
So the next question that we have, I think is for you, Dr. Skarbinski. So it says, people with severe ME/CFS are housebound and or bedbound. Was this patient population included in your evaluation? And if so, how?
Yeah, that's a great question, and it's something we're very sensitive to. So this is all electronic, so no one had to go anywhere. So this was all we did electronic and phone recruitment for this study. And again, we wanted to get out of our health system. We wanted to hear what people our patients are feeling without necessarily needing to come in. For patients who expressed a need that they were not able to complete a computerized survey on their own, we provided assistance to that. So our research assistants provided assistance with that to be able to help them complete a survey. If they said they wanted to do it, we would provide the assistance for that.
So much. Dr. Skarbinski, have you also looked at, or will you look at, the group of long COVID patients who do not meet your criteria for ME/CFS-like illness? If so, how do those compare to your two ME/CFS groups?
Excellent question, and we've just started looking at that data to try to all of that information to try to tease that out. I don't know yet. I will know in a few weeks as we sort of digest it all and try to figure it out. Remember, half our members, so half the people have had at least one episode of COVID in our system, which is similar to probably anywhere else in the United States. So it's a really large group, so we're really trying to tease that out. But that's a very important question.
Thank you. So I think we're going to try this hand thing again. I apologize in advance if it doesn't work. So whoever was the 125 at the end, if you'd like to try again.
Yes, hi, can you hear me? This is Eileen Holderman.
Yes, we can.
Thank you. My name is Eileen Holderman. I'm an advocate for ME, and I'm former CFS Advisory Committee member. Thank you for this call, and thank you for the presentations. My question is for Dr. Skarbinski. You mentioned a number of times the IOM SCID criteria, And I don't know if you're aware, but advocates have been protesting that since 2012, 2015, because we feel like the criteria is a simple checklist of 4 things and doesn't even begin to describe the magnitude of this infectious disease, this neuroimmune disease. And so I'm wondering why you used a non-expert criteria when there's one already available called the ME-ICC, the International Classification, International Canadian Criteria. Thank you.
It's a great question, and you know, and I'd love to learn more. We used the IOM criteria to have a starting point, and I recognize all the concerns about the diagnostic criteria, about sensitivity, specificity, and that it doesn't fully capture the full spectrum of symptoms with ME/CFS. That's the short answer, because we needed a starting point. It is the accepted criteria in the United States. We're doing a lot of work to really think about actually all of the associated symptoms, and both as a clinician and as a researcher, I would say it's I call it the penumbra, this sort of like associated symptoms that are not in that IOM criteria that are a very large cause of morbidity. And we're really interested trying to tease them out and see which ones how to put them all together, how to think about them, and then most importantly, how to treat them to improve patients' quality of life. So very well taken. Thank you.
So the next question is there any medical reason for diagnosing individuals with long COVID instead of ME/CFS other than the severity of symptoms, which may be due to shorter duration of condition? Is there any medical distinction whatsoever?
Yeah, it's a great question. I think this is where this is in relates to the second question. You know, as clinicians, providers, researchers, we need sort of some guidance and criteria. I think it partially depends on what people are coming in with and what they report, whether they're reporting the symptoms and they're saying, they're related to COVID or unrelated to COVID, how they're going to how someone might diagnose them with post-COVID conditions versus ME/CFS. I think this is where I know the NIH is putting out a call for this, and people are really looking at kind of creating a set of consensus criteria. And again, goes back to the other comment, having well done diagnostic criteria is going to be really helpful. And thinking about the full spectrum, just because you meet X number of symptoms doesn't ever describe you as a whole person for any disease process. So I want to just be clear that that's medicine uses small labels, but that doesn't just mean that, but it's never describes the whole person. And we understand that in this condition and all other conditions.
Thank you. So the next question is, was there anything in these data that surprised you? You mentioned comparing patients with different duration of illness. What else is next?
So our next steps are big things that we're really interested in. Number one is repeat survey. And we're planning on, we're in the process of re-interviewing or reassessing everybody this year. So this will be 1 year later, and hopefully next year and the year after. That's first. So that's really understanding stability of symptoms and duration of symptoms and changes in severity. That's number one. Number two is really teasing out for those who do not have chronic fatigue syndrome after COVID-19, what are the true symptom burden and what are the differences in symptoms that people get after COVID-19, and thinking about COVID-19 as the incident event that then leads to certain other things. And it's really important, again, remember, 50% of the country had it. This is huge numbers of people have COVID-19 and will have COVID-19. So that's number two. And the third is really trying to understand the associated symptoms and trying to tease apart what other conditions are associated. And we really have a lot more work that we're doing around things like pain, things like IBS, things like fibromyalgia, other associated conditions which cause, again, as I mentioned, substantial morbidity, and if we had better solutions could really improve patients' lives. Those are the kind of 3 big buckets we're working on next.
Thank you. So the next question is, what proportion of people that you identify with symptoms had an ICD code in their record that pointed to ME/CFS? Did you identify a lot of people who are not actually diagnosed with ME/CFS?
Yeah, and this gets at this question of diagnosis, under and over diagnosis. So a very small number of patients, and I'm going to say 2%, 3% of patients had either a post-COVID conditions diagnosis, and this is what used to be PASC, post-acute with sequelae of COVID. This was the first set of codes that came out, or an ME/CFS diagnosis in the chart. So very small. So this is kind of why we're kind of thinking a lot about this over and under diagnosis question. These patients are out there. We are not meeting their needs. We need to think about how we're finding them, their needs are getting addressed in the health system, and how we as a health system track it. And I know diagnosis codes are not the most interesting thing out there, but they're actually extremely important for any clinical enterprise, for any health system, is to have a clear sense of who's getting diagnosed and who's not getting diagnosed.
So the next question is about variants. It says, could the results that show the significant number from pre-Delta variants be the result of lack of vaccination, the 6-month requirement to obtain an ME/CFS diagnosis, and or the delay many folks are having in accessing care post-infection?
I think the variant and vaccination question is going to be extremely important. We have sort of early signals that suggest that vaccination, and even in one of our more in-depth analyses that I haven't presented here, that vaccination might be protective for that. Having had an episode of COVID after vaccination might be protective. So vaccination is protective from developing post-COVID conditions, and in this case, ME/CFS. So that's one thing. So I think vaccination is really important. And as we scale up vaccination in this country, that might make a big difference. That's number one. And I do think the variants are really important. We do a lot of other work on SARS-CoV-2, the virus that causes COVID-19. And we certainly see very different manifestations of severe disease after everything that came before Delta, and Omicron. And I do think variants might actually play a very important role. Good news might be is that Omicron might be, which is more transmissible, and what think about estimates around 40% of Americans have been infected with Omicron, that Omicron might be less likely to be the incident trigger for potential ME/CFS or other post-COVID conditions. We can't say that definitively, but I think that's where there's some evidence from us and from others that suggest that.
Excellent, thank you. Do you have any indication whether or not there's a greater risk of long COVID or ME/CFS with repeated COVID infections?
It's a great question. Stay tuned for our next analysis. That's the one we're doing, is trying to really tease apart who develops symptoms after a COVID episode and what are those risk factors in terms of really thinking about vaccination, repeat episodes. Quite frankly, it could go both ways because you do develop some naturally induced immunity from infection. So I don't know the answer to that. So we're gonna have to see.
Okay, I think we're going to try to do another hand. Hopefully this will work. I'm going to try to take a call from Bridget. Can you try to unmute, please? Or maybe it's Liz. I'm sorry, I can't. Having technical difficulties here.
Hi, if it's Liz, I'm here.
Hi, Liz. We can
Hi,
hear
terrific. You. Yeah, so my comment is for Dr. Cope, and let me just say thank you, Dr. Skarbinski, for doing the work. But Dr. Cope, I want you to know that I live here in Atlanta, and we had multiple people go to the CDC to see the blue lights. You were going to light up the Atlanta campus. We had multiple people go to the campus to see the blue lights. We failed to see any lights. This is emblematic of what we've come to expect from the CDC. Y'all diminish your credibility when you say you're going to light up the campus. That gives us awareness, and nobody saw the lights, y'all. So for you to reframe it as highlighting your efforts to recognize us on May 12th, it just doesn't hold water. And I say this with respect. You are burning bridges with your best allies, with your best friends. I need you to succeed because my life depends on it. You had a gentleman call in earlier who wasn't able to speak. He said he was from the Incline Village outbreak. He's been here since the 1980s. There's got to be more urgency from your end.
For your comment, I appreciate it. So the next question is, there's an ME/CFS clinic within Kaiser and developing long COVID clinic. What type of clinic do you feel is best equipped to serve post-COVID ME/CFS patients?
We're actually actively thinking about what the best way to tackle this is. And actually, I think because a lot of what we're thinking about post-COVID is changing right now. And that field is rapidly developing. So I think we're thinking about it. I don't have a off the top answer, best solution.
So scrolling. I apologize in advance. We have got a ton of questions. I don't think we're going to be able to get to everybody. So the next question is, what is the treatment protocol for those with ME/CFS? And I'm not clear if this is for CDC or if this is for you, Dr. Skarbinski, related to your study. Would you like to take a first answer to that?
I guess that's a little bit of a vague question, so I'm not sure. I'd need a little bit more detail about which aspects we're talking about.
All right. Okay, sorry about that. So it seems like existing disease burden is much worse due to ME/CFS before COVID. So if 50,000 affected total, I think Kaiser needs at least one MD per 1,000 patients. Can Kaiser train 50 ME/CFS doctors with expert training such as the Bateman Horne Center?
Great question. So we're scaling up. So if you're asking about the clinical program, we're scaling it up and thinking about how to best organize it. We are definitely going to be different than a clinic like the Bateman Horne Center. Partially, we serve a distributed population across a large geographic area, so it's thinking about how to make sure that we have knowledgeable providers across the spectrum and that are geographically located. We use a consultative model primarily in partnership with a lot of the specialists we have already locally based, and that's primarily not to have patients to travel to a single location or even 2 or 3 locations. But that's going to be our model. Our model is always going to be a partnership model with providers, not just ME/CFS specialists, but specialists across the board. And because many of the treatments, and someone asked about treatments, it's kind of hard to describe all of them, are going to be dependent. Some may involve neurologists, cardiologists, physical therapy, occupational therapy, et cetera. So we're going to mental health, psychiatry, behavioral health. So we're going to use a network of providers across the board for what the patients need.
All right. The next question is, where do patients fit into these groups who did not have a positive test for COVID, but had a COVID-like illness and developed ME/CFS symptoms after 2020?
So we use data to figure out who's had COVID. We use both data from testing, so testing testing data, tests that were conducted here within Kaiser, as well as patient self-reports. So we actually take a detailed COVID history. So we use both sources of information and cross-tabulate them to assess who has had COVID.
All right, excellent. So then the next question, I think this is the last question we're going to be able to take today, and I think this may be for CDC here, but feel free to jump in if you'd like, Dr. Skarbinski. Where do you recommend that we go for help? What organizations or doctors can provide support for ME/CFS like symptoms post-COVID?
So that is one of our most important issues. And that's why we've been doing what we can to increase educational opportunities. CDC does not have a list of physicians or clinics for people that we can recommend for people. But there are other organizations that do provide these lists, and there aren't enough of them. We understand that.
All right, so thank you everyone for taking the time to join us this afternoon. A reminder that we'll be posting the slides on our website ASAP, and we'll have a video recording and transcript posted as soon as they're available. We hope you leave with a better sense of information on ME/CFS, and on behalf of the entire ME/CFS program, we wish you the best as we head into the summer months. Thanks so much.